Ladies and gentlemen, distinguished guests and esteemed professors and doctors, welcome to Alameda Neurosciences Center of Excellence launching event, where the mysteries of the mind will be unraveled and the extraordinary become the new norm. This is Sara Abu Al-Ayoun. I'm the Marketing Director of As-Salam International Hospital, Maadi, and I'm beyond honored to be the MC for this amazing night. On behalf of Alameda Healthcare Group, we extend the appreciation for your presence today. Today, we come together to celebrate the convergence of brilliant minds, cutting-edge technology, and unwavering commitment towards unraveling the complexities of the most enigmatic organ known to humankind. The Neurosciences Center of Excellence stands as a beacon of hope, a sanctuary for groundbreaking research and groundbreaking breakthroughs. Throughout today's event, we will be privileged to witness captivating keynote speeches, retrieving panel discussions, and groundbreaking presentations from luminaries and forefront of neurosciences field. Their insights, wisdom, and expertise will undoubtedly leave an indelible mark on our collective consciousness, propelling us towards a future where neurological disorders are conquered and the human potential is unleashed. We'll begin our journey this evening with the luminary in the healthcare industry. His dedication and strategic vision have been instrumental in guiding our organization towards excellence. Please join me in welcoming our visionary leader, the Group CEO of Alameda Healthcare, Mr. Neeraj Mishra.
Good evening. Last week, we were in Alexandria. How many of you were in Alexandria with us? Can you raise your hand? There are a few, not our people. I'm talking about guests. And we were talking about Center of Excellence. And today I am very proud that we are launching we have 8 Center of Excellence, but we have not launched all of them. This is the 4th one we are launching in last 1 year. What is the meaning of Center of Excellence? This is what I said during Alexandria speech, and I will repeat it here again. You will hear this term, Center of Excellence, again and again and again, not by us, but also by every hospital. Everybody says that I have Center of Excellence. Long back, when I was having a conversation with one of the very eminent leaders in healthcare industry in the United States, I was given a definition of Center of Excellence. They said Center of Excellence has certain requirements. The first requirement of Center of Excellence is that you need to have focused, dedicated infrastructure, cutting-edge technology, very well-trained doctors, dedicated staff, focused on that particular specialty, going through and through in subspecialties in that particular global specialty, getting yourself internationally accredited by top-notch institution, and focusing in teaching and research. Today, when we say that we are launching the Institute of Neurosciences or Center of Excellence of Neurosciences, I can proudly say that out of the parameters I have mentioned, except the last parameter, which is not happening inside our hospital, but the professors who are working with us are doing it outside of the hospital, which is the education part, because we are not allowed to do education right now in Egypt as private healthcare provider. Other than that, all those parameters are met. You will see the eminent professors talking today. They will talk about the infrastructure, which we have in all the 4 hospitals, very focused and dedicated around neurosciences, which includes neurosurgery, which includes neurology, which includes neurophysiology. Most advanced technology. The microscope which we have, and Dr. Romy will speak when he speaks, is the most advanced in Middle East and Africa. We are the only provider in Middle East and Africa, and when I say Middle East, I am including Saudi Arabia. We are the only provider in Middle East and Africa to have this advanced microscope. None has it. And with the devaluation, I doubt anybody will have it. The navigation system. I don't know if you know it, that most of the hospital, if they have to use navigation system, they rent it. The system roams around the whole country, which has its own challenges. We were in the coffee table and we were having this conversation with Dr. Tariq Lutfi. I don't know where he's sitting, he was sitting there. And there was a debate between him and Dr. Romy about moving our navigation system between our 4 hospitals. And that is the time I realized that this is so delicate a system that you cannot easily move it. Because if you move it, you lose the efficacy of the system itself. I think we are the only hospital in the country, I don't know if, correct me Dr. Romy, we are the only hospital in the country which owns its own navigation system. Now this is the investment in the cutting edge technology. So having the dedicated infrastructure, having best in class technology, professors I will not speak about, or the doctors who are working with us, I will not speak about. They will themselves, when they come to the stage, they will speak about it. But I believe that we have the best of the clinical talent available in the country working with us in our 4 hospitals. And then comes the accreditation. Do you know that we are the only hospital group in the country to have our stroke program accredited by Joint Commission International? Out of the 4 hospitals, the 2 hospitals, Darul Fawad in 6th October and Salam in Mahdi, are accredited as Joint Commission International CCPC accredited for stroke program. Now you might have heard from a lot of people that we have stroke center. We get ourselves audited on this pathway from the best in the world. So this is on accreditation. In terms of the subspecialty focus, the collaboration of multidisciplinary team within the frame of neurosciences, I think this I will leave to Dr. Romy and team to speak about it. But as an administrator, I can tell you that if we have any issues related to neurosciences in our facility, any patient who walks in, whether in ER or in OPD, the team is there where the care can be provided under one roof. I doubt that there is anything left in the segment of neurosciences where the patient will be referred outside because we do not have their services available inside our hospitals. For me, this is the definition of Center of Excellence. We took time. This readiness took time. We did not come to the market. We are there for 23 years. The group got launched in 1999. Salam started in 1984. Darul Fawad started in 1999. We took our time to come to you to announce that we are Center of Excellence. So this announcement which we are doing today is been done with a lot of hard work, a lot of effort, and putting up the whole setup together and integrating the architecture of the group, the 4 hospital, followed by a home healthcare business, which is Tabibi. So we also have a home healthcare business. So tomorrow if a patient needs a rehabilitation, we have a rehabilitation business. We have a German rehabilitation center. So after, let's say, stroke, a patient requires rehabilitation, we have that. You need a care at home, we have that. We are not outsourcing anything. We are not asking people that this is my job, after this please go to X, go to Y. No, the whole spectrum is provided by us under the banner of Alameda Healthcare. So we are announcing today to you that we are launching the Institute of Neurosciences, focused from pediatrics to adult. Dr. Biltagi is sitting here. I am sure he will be speaking about pediatrics also today. Focusing on subspecialties within the frame of neurology, within the frame of neurosurgery, within the frame of intervention neurology or intervention radiology and neurophysiology. We will speak about the whole spectrum today, and I hope and I request that in case you have a friend or a family or somebody who requires the care on this frame of neurosciences, think about it where you are referring this patient, because the patient requires extraordinary care when it comes to brain. When brain stops, everything stops. So we can proudly say today that after this launch, we would be the best caretaker of the brains of the people in the country of Egypt as well as in Africa. Thank you very much. Thank you for coming today.
And now, we're also privileged to have Mr. Haitham Dawood, the strategic lead Egypt and Libya, representing Medtronic, a company that has been the forefront of medical advancements. And we are honored to have him joining us today as our partners in success as well. Please join me in giving a warm welcome to Mr. Haitham Dawood.
Good afternoon. Good afternoon, dear professors, eminent guests. Thank you so much for giving me this opportunity. Mr.
heads of the 4 hospitals, distinguished professors, dear guests, ladies and gentlemen. My name is Rami Amin. I'm professor of neurosurgery in Cairo University. I'm also the director of the neurosurgical departments in Alameda. I'm talking today about an important topic which was planned, and we called it empowering neurosurgery. I'm just showing this video about the operating rooms in As-Salam Maadi, which were all now new operating rooms, capsule-like rooms, and we are going to see our new equipment. This is room 3.
ألميدا. احنا هنا في عمليات الدور الثالث، ال7 اوض عمليات كلهم كبسولات ذات التعقيم، وهندخل دلوقتي اوضه 3 اللي هي اوضه جراحه المخ والاعصاب. احنا هنا موجودين في اوضه 3 اللي هي اوضه جراحات المخ والاعصاب في عمليات الثالث في مستشفى السلام الدولي في المعادي. زي ما انتم شايفين الاوضه كلها كبسوله، حتى دوران الهواء وسيركيليشن الهواء بيعدي على فلاتر دقيقه جدا عشان ضمان ان مفيش اي ميكروبات، لان الكلام ده مهم جدا لعمليات جراحه المخ والاعصاب ان ما يحصلش اي عدوى او التهابات. ورايا هنا هتلاقوا احدث ميكروسكوب في افريقيا ومنطقه الشرق الاوسط كلها، ده الميكروسكوب اللايكا الافيرو. ده ميكروسكوب امكانياته عاليه جدا جدا جدا. الميكروسكوب ده مربوط بجهاز الملاحه برضو اللي انتم شايفينه هنا. الميكروسكوب ده بيقدر ان هو يكبر ويدي اضاءه مركزه ويتتبع حتى الجراح وهو بيشتغل، زي ما هنشوف دلوقتي القدرات بتاعته. انتوا شايفين هو شايف حتى النسيج نفسه، يعني الفايبرز بتاعت النسيج نفسها. هبص هنا كده، انا هظبط على ايدي اهو، شايف الايد كلها، وبعدين اقدر ان انا اشوف حتى التجاعيد البسيطه جدا بتاعت الايد. هذا الميكروسكوب بيتميز كمان ان هو بيقدر ان احنا اذا حققنا صبغات عشان تبين خلايا الورم اللي مش باينه بالاضاءه العاديه انه يبينها، فيبقى في استئصال اكمل للورم. وبيعمل حاجه اسمها ايمج فيوجن، يعني اقدر اشوف الصور بتاعت جهاز الملاحه وانا باصص من خلال الميكروسكوب، وده بيدي للجراح التحكم ان هو يبقى عارف كل الاعصاب والشرايين والاورده اللي حواليه. ده جهاز الملاحه، ده احدث الاجهزه بتاعت الملاحه بتاعت جراحات المخ، شركه ميترونيك الامريكاني اللي هو بنسميه ستيلث 8، ده احدث واحد. وهنبص هنا هنلاقي فيه كاميرات، الكاميرات دي هي اللي بتشوف المريض وبتقدر ان هي تتتبع ايدين الجراح، بيشوف المكان بتاع الورم، وبيشوف ايديك وهي بتتحرك، وبالتالي يقدر يعمل لك يوجهك كده زي الملاحه بتاعت الطائرات، ان هو يوجهك للملاحه اثناء ما انت بتعمل هذه الجراحه. الكاميرات دي بتبقى موجوده دايما شايفه المريض طول الوقت اثناء العمليه، وايضا الصور دي بتبقى بتتحرك وانت بتحرك ايديك اثناء الجراحه. هذا الانتجريشن او الدمج ما بين الاثنين بيتم بسهوله جدا، لان الكاميرات هي اللي بتعمل الحركه، وكل المعلومات بتاعه المريض متخزنه في الكمبيوتر بتاع هذا الجهاز. وهنشوف الكلام ده في العمليات اللي جايه ان شاء الله.
Okay. I started in Salam International Hospital in Maadi in 1991. At that time, yeah, we had a very ancient microscope. It had only one side for the surgeon, and the senior professors used to call it a very romantic microscope because the light was very dim. In 2020, I had a meeting with Mr. Neeraj about what's the plan for the neuroscience and for neurosurgery. And I'm glad and thankful to him that he decided to empower the neurosurgery. And now what we have is the cutting edge equipment, the state-of-the-art equipment in our hospital. It's no less than any other part in the world. So we decided after that to empower all the neurosurgical and neuroscience services. What is neuroscience? It's neurology, which is the mother branch, neurosurgery, neurophysiology, neuroradiology, interventional neuroradiology. And we have here distinguished professors in all these specialties. So it's a teamwork. This is our new microscope, like Mr. Neeraj was just saying. It's not anywhere in Africa, North Africa, or even in the Middle East. It's the Avero 8 digital microscope, which unites the information from the fluorescence, the navigation, endoscopic images. All this is integrated to give precise information and precise neurosurgical operating. As you can see, the microscope has its screen, and this screen is very important because the scrub nurse or even the anesthetist will be watching, and you have the other big screen for the assistant or any other teaching purposes. It has many fluorescence options. The FL400 for oncology, the FL560 also for oncology, and the Glow 800 for the brain vessels. So there is no microscope at the moment in the land with all these capabilities. This microscope also has a transverse beam splitter and two optics. It used enhanced depths and field high resolution fusion optics. So it has, when it has two separate beam paths, one beam provides high resolution and the other beam provides depth of the field, and they merge together, and it keeps giving you, while you are working, without needing to change your hands or touch anything, the best image ever. This is again the Leica Avero. Neuronavigation provides the surgeon with the ability to see a patient's anatomy in 3 dimensions and accurately pinpoint the location in the brain or the spinal cord. You can actually plan your point of entry, you can plan your trajectory, you can see the ends of the tumor in each direction. What we have now is the state-of-the-art Stealth Station S8, which again is not present in any other hospital in the land. This is the S8 navigation system, and you can see also that it has 2 screens, and the smaller screen is for the nursing to be following up with the surgical team. This is just a diagram, and you can see the navigation, the S8, the cameras, and the surgeon operating, and you can have real-time
camera as well, which prevents you from deflecting from the target after the brain shift. What's the application of neuronavigation? Tumor localization, to define the tumor margins and the limit of the excision. It's used also for stereotactic biopsies and for frameless stereotactic biopsies as well. Localized, encased, and displaced vessels, which makes deficits post-operative much less. Epilepsy surgery and deep brain stimulation surgery for Parkinson's disease and so on. This is a diagram from the frameless biopsy. This diagram, you can see, this is the patient that we just saw, and we are going to see also videos for her. She had a recurrent high-grade glioma. I don't know if you can see the burr holes. Can you see the burr holes here in that image down and on the right? So it's a recurrent. And using the brain navigation, you can get the edges of the tumor, especially that it is surrounded by a gliotic tissue. And it's not hemispherical, so you can get the edges of the tumor. Here it's getting the anterior limit and the inferior limit and so on. Here it's getting the medial limit as well. So this is using the microscope with the least magnification. You can see now that the plane between the brain and the recurrent high-grade glioma is being achieved. It was pinpointed using the navigation first. The medial part of the tumor. And you can actually see that the brain is pulsating, which also means that we have very good neuroanesthesia. Again, the anterior plane. The medial plane attached to the falx. The inferior plane. Can you see these two tiny black dots? This is what I was talking about. The two tiny red dots. This is the microscope calculating the distance and the depths until it gives you the best image. It does that on its own. So anyhow, this is a very important function for the neuronavigation system. If you have a tumor
if you have a tumor such as this one, which is underneath the surface of the cerebellum at quite a depth, the navigation can pinpoint the location, and you can choose your entry point to make the least or no deficit at all. Now, for our friends from the medical insurance companies attending here, what does that have the impact from the financial standpoint to you? I'm going to give you a study that was conducted in the US in Indiana, and it actually says that if you use microscope and any equipment like navigation that will give you brain path, the insurance company saves 54% on the long run. You have less hospital stay, less operative time, less ICU time in the ICU, no deficits, more radical tumor excision, less need for radiation and chemotherapy, nearly no need for physiotherapy. So on the long run, you save 54%. And this was the study. It was called from the NICO group in Indiana, which analyzes the health care cost there. Thank you so much.
Thank you, Professor, and sorry for the inconvenience. And now, please join me welcoming Dr. Ahmed Abdelalim, Professor of Neurology, Cairo University.
Good evening, ladies and gentlemen. My name is Ahmed Abdelalim. I'm a professor of neurology at Cairo University, and I'm the director of the Stroke Center at Cairo University and a member of the executive committee of the Middle East North Africa Stroke Organization. I'm really proud to be here today celebrating this achievement. It's a work of years, and I'm really proud to be a part of this team. And my talk today will be on the stroke service and how it should be and how we do it. So I hope I can make it in a short time as easy as possible. Of course, we all know that brain tissue, if we have a damage to the brain tissue, it's irreparable. So we say that time is brain. So with every minute passes without rewiring the brain again or giving the brain the blood supply that it needs, so we will get irreparable loss and damage which will impact the patient's own life and the surrounding life. It will impact the society, it will impact the economy, everything. So especially in stroke, we need to move very fast and in a standard way to make sure that we don't lose brain tissue. If we can look broader, the stroke is one of the worst diseases that we can deal with in terms of disability and mortality. It causes a big burden on economies, and if you look into the studies and in the ranking, you will find that it's the second leading cause of death, and if you put disability, it will become the third leading cause of death combined with disability. So we are dealing with a major disease, and I'm a neurologist, and I say that if I say that neurological emergencies, we can say that the stroke itself and the other vascular diseases will account for at least 80–90% of our emergency work. If we look at the expenditure because of the stroke, and here I'm not talking about how governments spend. This is a private sector spending. And if we look to each country, this is how the private sector covers the stroke service and out-of-the-pocket payments from the people themselves who have stroke. And we can see that the developing countries are really suffering, that they pay out of the pocket, and insurance systems are paying too much in comparison to the developing country, maybe on the contrary that we think, because these countries are covered with better services, maybe better criteria for selection of patients, and at the end, the cost effectiveness is much better. So in developing countries such as Egypt, we are with how we run and how the cost is covered. And if we look to a country like Canada, when they implemented an effective stroke service, we can look to what they have spared. This is, of course, this is the direct cost where the patient is not working or he dies, and the indirect cost that comes from the surrounding of the patient. Somebody's taking care, he will go to an institution, he will have cost of treatments and rehabilitation. So we can see 18 billion from the indirect and 13 billion from the direct. So we are not talking about a little amount of money. This is big money. So let's put a rule that stroke management is not a choice. Stroke management is a human right. If you see the burden that it happens, so it's a human right. It's a responsibility on us to give this kind of treatment and at its best. So where should we treat a stroke patient? Should we treat him in any hospital? If we look to the guidelines of the major societies, this is the American Stroke Association, and we look to the colors, green and blue. This is the highest evidence that we should treat patients in a stroke unit, in a stroke facility, using a standard stroke care and a multidisciplinary stroke team. So this is not a matter of debate. If you don't offer this service, then you are not treating stroke properly. These are the highest levels of guidelines. And if we can see here the length of stay when we treat patients in stroke units compared to patients outside stroke units, there's a big difference, and difference in outcomes and the quality of life of the patient later. And of course, this will immediately give us some statistics about better mortality, less complications, less length of stay, less independence, and the patient will discharge home with least disability or normal if we can do that. So what makes a stroke unit a stroke unit? How can we call it a say that these 2 beds are stroke beds, and then tomorrow they will be surgery, on the next day they will be cardiac cases? We have to have a dedicated place. The number of beds is another thing. It depends on your flow, on how you plan your service, but you have to have a dedicated space. Of course, you have at least that will give you the way to differentiate what's the cause of a stroke. Is it a stroke, and what's the extent of the stroke, and how will you treat the stroke? And of course, the 2 main core therapies that we will need in stroke, it's the revascularization either by RTPA, the IV RTPA, or the mechanical thrombectomy. I'm here talking about the things that you should have to call your service a stroke service. And of course, it does not only, you don't only treat ischemic strokes, it's extended to other things which may be representing about 20%, like the hemorrhages and the subarachnoid hemorrhage and the vascular malformation, and all of this requires also set up standard care protocols and everything. So who are working inside the stroke unit? Of course, it jumps to our minds that we will need stroke doctors, stroke nurses, but it's not just that simple, because there's a lot of people working inside this, up to the administratives and the audits and everyone dealing with this service. If they are not a part of the team and they are not educated well how to go within the pathway, you will lose time and you will lose everything. Of course, logistics. You have to have a stroke code, which when you push a button, everyone involved in the stroke treatment will be notified and everything will be prepared to treat the patient. You don't leave this to coincidence or to personal evaluation. You have to have a stroke code, algorithms, and of course, the fine details, who will dispense the RTPA, and everything, all these details should be put clearly and have enough time to train on it so that you have a real stroke service. And at the end, the accreditation. The accreditation is important because it's like a license. And of course, in Egypt, we are lagging behind in accreditation, not just in stroke. And recently, maybe in the past few years, we have now a national agency for accreditation. So accreditation is coming anyway. If you will not seek accreditation, it will come to your door. But in our case, of course, we will talk about how we were seeking accreditation long before everyone thought about it. So I will talk just about the stroke unit that I work in now in As-Salam Hospital in Maadi. If we put the criteria of the stroke unit and apply it, you will find that it has everything, and like Mr. Niraj said, that we have all the facilities, all the equipment. We do not have to refer the patient to another center because we have something lacking. And this happens in other hospitals. And they, even if they don't have the full service, they will have to make a deal with another hospital to maybe refer the patient to have a thrombectomy or something. But we have everything that you can imagine for a stroke unit or center to have it from the door until if the patient have any complications, we have some of the best ICUs and very well equipped. When we talk about the team, it's not just the work of a doctor or a nurse, it's a multidisciplinary team of many specialities that will be involved, from the neurologist, the neurointerventionist, neurosurgeons, stroke nurses, and rehabilitation, and of course, other parts of the team. Everyone is doing his part as planned, and of course, we have, I think in As-Salam and in Alameda, we have some of the best stroke neurologists and stroke specialists, and I can guarantee you that because I'm in the field and I know well the other stroke centers, and I know well the quality of the doctors working in the center. So we have some of the best, I can assure you. Logistics, we have everything as it should be, the pathway, and every single possibility that you can have. You don't leave everything to coincidence, every single possibility, and you are trained. And at a time, you don't even need to look at these algorithms. You just see them regularly if they are updated. But you have them in the mind because you are a practicing one. You are a center of excellence. People refer strokes to you, so you have a good flow, so you have a good experience. When it comes to performance, so you have a stroke unit. But what makes your stroke unit a good stroke unit? You have to have metrics. You have to have KPIs and things to prove that you're working well. And of course, the training is one of the most important things. You don't just train your team and leave them for like 5 years. And you make workshops, sessions, simulation, so that the team is always updated. And the audit. You cannot have a good service without the audit. You say that I'm fine while you are making mistakes. So audit is very important. And we have a great quality team in As-Salam also. They are always giving us KPIs and looking into the service, and these numbers are regularly visited, and we see if you're doing fine or not. So you're not just satisfied at the moment. You will always not be satisfied. If you're satisfied that there's something wrong, you will always seek a better service. In terms of numbers, if you are treating stroke patients and you exceed a revascularization rate of like 15%, between 15 and 20, you are fine. You are doing fine. So this is the international numbers. So our numbers are matching with most of the centers. And when we deal with people coming from maybe Europe and talking about the numbers, our numbers are good. So we are doing the percentage that makes you a good stroke unit. And we see here the improvement of the patients are keeping up with the performance, and that the percentage of deterioration is minimal. That's why, because the selection of patient is done based on criteria, on training, and experience. Experience is not an easy thing to have. So I think with experience we are having great results. And this is the percentage of improvement of patients, or the outcome that we expect from patients. And some months they are 100%, that they are short hospital stay, less dependence, and a better outcome. And of course, when we talk about the accreditation, as Mr. Niraj said, that this is the only center in Egypt that has this primary stroke program. JCI is not an easy certificate to get. It's one of the most difficult in the world. So I think it proves that you're working well. And the second thing, that we are acknowledged by the World Stroke Organization. We were awarded the gold status. It also comes from performance, that they revise how you work, the percentages of everything you do. Of course, one thing is very important. There are countries that say if you don't have a standard stroke service, then you will not be reimbursed. If I have a general hospital, for instance, and I don't have a stroke service, then when I send a claim that I want to reimburse the money that this patient has costed in treatment, if I don't have a stroke care, standard care and program, I will not be reimbursed. And I think sooner or later this will happen. in Egypt. Because why should I spend my money in a place that is not experienced, that does not have the standard care, while there are others who present the best service? It means that I will, in terms of cost effectiveness or health economy, it's not a debate. It's a logic thing. So I'll just give you a fast lab. This patient came to our center, and he had a cerebellar infarction. He arrived within 2 minutes. He had been examined, and he did the CT scan, and the decision for injection of RTPA was taken in less than half an hour. Of course, the door to needle, which the time from the door to the injection, is globally 60 minutes, and in stroke centers it's 30 minutes. When you go below 30 minutes, you are doing fine. And of course, you pursue less and less time. At the end, we injected the patient, and we found that the patient has stenosis in the artery. That's a multidisciplinary approach that I say. You don't just inject and leave him. You will complete his workup and then go to the neurointerventionist, Dr. Farouk, who performed this. And now the patient has been stented. So he got the full service under the supervision of experienced consultants in the best setting. And now this specific patient has zero disability. He came to the hospital with a disability. Now he can go home with zero disability. He will resume his life back. The second is a patient who was sent to a general hospital, not specialized, so they did an MRI, but they didn't have the treatment, so they referred him. And this is also a proof of how the performance, it's the time. This is the shortest time from the imaging to the injection in Egypt, which is less than 5 minutes. The patient came to the hospital with an MRI at the door. At this moment, 5 minutes he was injected. And of course, he improved. So this is just to give you an example on the difference between experienced and non-experienced centers. And of course, it doesn't stop at this moment. When the patient goes out, leaves the hospital, you have to follow him. We have a full program for care, after care, like outpatients and rehabilitation and booklets that gives full information. And of course, we have a chart, we have something to follow the patient upon and see how everything is performing. So at the end, I thank you very much, and I'm really proud to be a part of this team, and I thank Alameda and my colleagues for this great standard. Thank you.
Thank you, Professor. And now, please join me welcoming Professor Naveen Al-Fayoumi, Professor of Clinical Neurophysiology, Cairo University.
Good evening, dear. It's my pleasure today to present the clinical neurophysiology services in As-Salam International Hospital. First, I would like to speak about clinical neurophysiology. Actually, it is a vast topic creating a varied patient case mix, and it is one of the few specialties that really deals with both adults and children. Regarding referrals from all neuroscience specialties, neurology, neurosurgery, general medicine, musculoskeletal, orthopedics, pediatrics, intensive care unit, ophthalmology, and ENT. Clinical neurophysiology really involves the diagnosis of a wide range of conditions affecting the central and the peripheral nervous system. It's concerned with testing the electrical function of the brain, spinal cord, and nerves in the limbs and muscles. Actually, it is principally diagnostic, but it can also be necessary for ongoing management decisions, directly involving therapy for some conditions. Clinical neurophysiology unit here, it started providing its services since 2008 in Maadi branch, and since 2022 at New Cairo branch. Provided services, we present EEG, electroencephalography, digital EEG, long-term EEG, and portable EEG, electromyography and nerve conduction studies, evoked potentials by its modalities, brainstem, visual evoked potentials, somatosensory evoked potentials, and electroretinogram. Since January 2023, we've done 329 EEG cases from the outpatient unit at As-Salam International Hospital, outpatient clinic, 330 portable EEG cases in the ICU, and 639 EMG nerve conduction studies and evoked potential cases. This is the EEG machine in the outpatient clinic. This is a routine EEG which lasts from 20 to 30 minutes, is really the most basic and inexpensive EEG test for supporting the diagnosis of epilepsy. And despite advances in both EEG and neuroimaging, we still depend on the history, and the principal objective of routine EEG in the diagnosis of epilepsy is to capture the interictal epileptiform discharges. This is the role of EEG. Actually, we speak about epilepsy-related indications. It's for clinical suspicion of epilepsy or seizure, to consider the initial diagnosis of epilepsy, patient classification of epilepsy, changes in seizure pattern, suspicion of non-convulsive status epilepticus, monitoring status epilepticus, seizure frequency, effect of medications, stopping anti-seizure medications, pre-surgical evaluation, and also there are other differential diagnosis questions like psychogenic and non-epileptic seizures, loss of consciousness, disturbance of consciousness, encephalopathy, encephalitis, dementia, coma, and brain death. This is our portable EEG machine for cases in the ICU. Regarding the sensitivity of interictal epileptiform discharges in adult centers, initially revealed that it ranges from 29 to 55%. And it should be distinct and standing out from the background activity. For example, the type of epilepsy affects the sensitivity of routine EEG. For example, cases with or patients with Lennox-Gastaut nearly always have abnormal routine EEG with interictal epileptiform discharges. However, frontal lobe epilepsy patients may never have IEDs on interictal EEG. Other factors such as age, sleep deprivation, level of consciousness, is it generalized or focal epilepsy, temporal or extratemporal, anti-seizure medication, seizure frequency, activation procedures, all of these will affect the sensitivity of routine EEG. Generally, the sensitivity is around 50% for the initial EEG, and with repeated studies, it increases from 82 to 92. Extended EEGs can also increase the sensitivity. For example, in a study, the mean duration of initial interictal epileptiform discharges was 56 minutes in patients with temporal lobe epilepsy, and it was 22 minutes in patients with generalized epilepsy. Others also found that only 36% of patients had IEDs within the first 20 minutes of long-term monitoring, while 89% had IEDs in the first 24 hours. As we can see here, this is an EEG trace of generalized epilepsy. We can see the epileptic discharges in the form of spike and slow wave complexes, obtaining all the channels of the EEG. Regarding the specificity of EEG, specificity of IEDs is very high in theory, with false positive rates of about 0.2 to 0.5% in adults and 1.9 to 3.5 in children. But unfortunately, this specificity is sabotaged in the real world due to the very common and underreported problem of EEG overinterpretation. And also, it leads to a common scenario encountered at epilepsy referral centers. About 25 to 30% of patients previously diagnosed with epilepsy who do not respond to initial anti-seizure medication treatment, they do not have epilepsy actually. Differential diagnoses like syncope and psychogenic non-epileptic attacks are the leading misdiagnostic conditions in adults and adolescents. Overreading of EEG is one of the causes of misdiagnosing of epilepsy, even if the patient history is not particularly suggestive of epilepsy. Reasons for overreading is due to misconception, significance of some patterns like phase reversals, lack of EEG training, and history bias. Most overreading comes from the interpretation or the wrong interpretation of some transients, which are benign transients appearing in the normal EEG in normal population, especially in drowsiness and light sleep. So they are benign variants, and they shouldn't be encountered as epileptic discharges. And the misdiagnosis of epilepsy has a significant impact, for sure, of a patient's life with the initiation of anti-seizure medication associated with its side effects. Regarding the value of EEG in the diagnosis and in the classification of epilepsy, IEDs captured on routine EEG, if present, it should be yield information that allows the classification of epilepsy, but we should put the clinical history in context. These findings should be put in the context of the clinical history, as for example, interictal EEG alone. For example, generalized spike and slow wave complexes may also be present in patients with focal seizure disorder causing bisynchrony. So in this case, we can depend on the history more. Role of EEG in making decisions regarding the anti-seizure medication withdrawal. In patients with epilepsy who are seizure-free for a long time, from 2 to 5 years, while taking anti-seizure medication, one can consider withdrawing anti-seizure medication to eliminate adverse effects of the medication. However, half of the patients will have recurrence, and it is important to estimate the risk of relapse in each patient before making this decision. Several studies suggested that the presence of epileptiform EEG discharges before withdrawal is associated with the relapse. And the presence of these discharges together with other clinical variables are the input information for a nomogram that can predict relapse. The importance of epileptiform discharges for decision of withdrawal also depends on the type of epilepsy. For example, patients with idiopathic generalized epilepsy may be of significant risk of recurrence when persistent EEG abnormalities are present. However, patients with self-limited epilepsy like centrotemporal spikes are of low risk of relapsing. In patients with pharmacoresistant focal epilepsy, in the appropriate clinical setting, such as after resective surgery, the presence of IEDs at 6 months after surgery, this suggests seizures may recur after withdrawal of medications. Regarding the outpatient short EEG services, this is a routine service. EEG here, we do it for 20 to 30 minutes in the outpatient clinic. There are some limitations. We need, of course, to increase its sensitivity by doing more and more EEGs, as the sensitivity increases by the fourth EEG up to 90%. Outpatient prolonged EEG, we do it also. It is better to do, or it's less expensive, than inpatient EEG monitoring. So prolonged EEG can capture more and more interictal epileptiform discharges, as we said before. Regarding the use of EEG in the ICU setting, in ICU setting, we do two types of EEG. Either short, which is less than 1 hour, routine EEG, and prolonged study, which lasts up to hours or even days continuously. EEG has been obtained in ICUs for decades, and in the last 20 years, there has been an explosion in the use of prolonged recordings because of the technology, the videos, the very fast processing of the machine. So all of these help us to use it more and more, and to use the prolonged recordings. Furthermore, it becomes clear that many cases of altered mental status may be the result of unrecognized non-convulsive seizures or status epilepticus. So EEG becomes an important tool for making the diagnosis of guiding treatment. As we see here, we can see this is a trace of EEG of a patient in the ICU. Actually, this patient had arrest. We do EEG after cardiopulmonary arrest, actually in the first, in the third, in the 7 days to detect the prognosis of the patients. And actually this patient, starting from the first day, he had suppression pattern of the background activity and which is of very unfavorable prognosis. Another EEG trace of a patient in the ICU, we can see here status epilepticus, and we can see the spike and the spike slow wave complexes all over all the EEG channels, and they are evolving in duration and in frequency and distribution. We'll come next to the second modality and the second service, which is the electromyography and nerve conduction study. It helps to diagnose injuries and the conditions that affect the muscles and the nerves. And we often do this test alongside with a nerve conduction study. Here we can see this is a nerve conduction study test. We put electrodes and stimulation to stimulate the nerve and to gain its effect. And this is the EMG we use here as we see needle electrode. Electromyography is more involved than nerve conduction studies, and as we said, we use a needle electrode, and we ask the patient to flex or relax his muscle and to contract it just to gain the motor unit potentials of the muscle and to comment upon it. Both tests are very useful in diagnosing neuromuscular diseases such as muscle dystrophies, myasthenia gravis, nerve problems in the spine such as herniated discs, nerve problems and entrapments such as carpal tunnel syndrome or ulnar nerve entrapment, peripheral neuropathies, pinched nerves, Guillain-Barré syndrome, sciatic nerve problems. Also, it is very important in diagnosing nerve injuries in the context of the clinical history. It helps in localizing the site, the type, the severity, and in the prognosis of the nerve injury. Third modality is the evoked potential. Neuroelectric responses to sensory stimuli demonstrate abnormal sensory system conduction and reveals subclinical involvement of the sensory system. In theory, almost the best is visual evoked potentials, then the somatosensory evoked potentials in diagnosing of multiple sclerosis. Visual evoked potentials is a sensitive indication of abnormal conduction in the visual pathway. As we see here, this is a machine in a patient clinic. The patient sits in front of this checkboard and he concentrates in the center of the screen to get the responses, which is called the P100 response, and to decide if it is normal or abnormal response. Regarding the short latency somatosensory, we can do it over the upper limbs and the lower limbs, and synaptic potentials from successive anatomical neuronal generators with within the dorsal, lemniscus, and thalamocortical sensory system. Also, in our clinical practice, somatosensory evoked potentials are typically used to investigate patients with possible multiple sclerosis and myoclonus, and intraoperatively to monitor the integrity of the sensory pathways during the surgical correction of spinal curvatures as a guide to prognosis in post-traumatic and anoxic ischemic coma in ICU. Lastly, the brainstem auditory evoked potential. It assesses the auditory pathway starting from the 8th nerve till the lower midbrain. These are the traces of the 5 waves arising in the brainstem auditory evoked potentials. and it assesses the conduction through the lower brainstem auditory pathways. Actually, it is to investigate patients with possible multiple sclerosis, as we said before, and structural lesions of the brainstem and posterior fossa intraoperatively to monitor the integrity of the auditory pathways during neurosurgical excision of the posterior fossa tumor and the guide to prognosis in post-traumatic and anoxic ischemic coma in the ICU. Occasionally, sometimes in hearing assessments, we use it. And lastly, this is the electroretinogram. This is the ERG, which tests the rods and the cones system. It is important in would be of importance in arteriosclerosis, the giant cell arteritis, retinitis pigmentosa, and trauma. Clinical neurophysiology services wouldn't have been provided and done except with the hard working of the eminent team, Professor May Bshir, Radwa Azmi, Iman Meher, and myself, Niveen El-Fayoum. And thank you very much for your listening.
Thank you, Professor. And now we reach the panel discussion part. Just give us a few seconds to do the setup.
To have Professor Dr. Tariq Lotfi, Professor of Neurosurgery, Ain Shams University, and Head of the Neurosurgical Services in Salam Hospital in New Cairo. Professor Dr. Mohammed Biltagi, the country's leading pediatric neurosurgeon and pediatric oncology surgery. Professor Farouk Hassan, the eminent interventional neuroradiologist. Professor Ahmed Abdel Alim, the eminent neurologist. Professor Naveen El-Fayoumi, Professor of Neurophysiology. Professor Muhammad Rida, also a leading neurosurgeon and head of the neurosurgical services in Dar al-Fuad, 6th of October, and Professor Salah Hamada, a very dear colleague, and he's representing Professor Muhammad Basyouni, who came from abroad a bit sick, and he's presenting the Dar al-Fuad in Nasr City. Thank you. Will I start with Professor Dr. Tariq Lotfi to give us a short, brief account about the neuroscience and neurosurgical services in As-Salam in New Cairo, and your experience also about using neuronavigation for third ventricular tumors.
Good evening, everybody. My name is Tariq Lotfi. I'm a professor of neurosurgery at Ain Shams University. I'm one of the team at Salam Al-Atamiyya, the youngest giant at Alameda Group. We started just the last August with a soft opening, and the actual work we started at January. We do have a top managerial team with Mr. Narid above all, and Mr. Bobasi, and all the team. I don't want to skip anybody. We had really around 120 cases. We did all the neurosurgical spectrum, from trauma, spine, skull-base surgery, and endoscopic surgery like skull-base, pituitaries, and intraventricular tumors. We have collaborated with all the team in the ICU, neurology, and even we did a neurointervention coiling and stenting. We are honored to be part of this distinguished company and all the professors here. Thank you, Mr. Chairman, and all the professors in the whole group. Answering the question of the third ventricular tumor and the navigation and the neuronavigation, we actually use the neuronavigation in third ventricular tumors, as we all know, the neurosurgeons here and the neurologists, that we use the neuronavigation in a small ventricle with third ventricular tumors.
Tariq, just because most of the audience, some of them are not doctors,
okay.
You just want to tell them that the third ventricle is a very deep spot in the brain. Yeah. It's a very deep, narrow spot in the brain.
Okay. I may go a little bit general. With the third ventricle is a very deep spot inside the brain, as Dr. Rami said, and it's a very deep part, and it has the function of giving the CSF flow through the lateral and the fourth ventricle. And usually lesions at this level causing obstruction and hydrocephalus, which is the dilated ventricles. And with the use of endoscopy, we also can get rid of most of the anterior third ventricular tumors through endoscopy. But we need to have a lateral ventricular dilatation. In non-obstructed lesions, we have a small ventricle. So we have to use the navigation in these lesions because the minimally invasive surgery must be done. Thank you.
Thank you, Dr. Tariq. Okay, I'm going to ask Professor Mohammed Al-Biltagi about the use of navigation in pediatric skull base tumors. You are now the pediatric neurosurgeon for the group.
Okay, I hope. Anyway, my name is Mohammed Al-Biltagi. I'm the professor of neurosurgery at Cairo University and head of neurosurgery department at the Children's Cancer Hospital of Egypt.
I will humbly ask you to talk in Arabic.
أنا اسمي محمد البلتاجي، أستاذ جراحة مخ وأعصاب في القصر العيني ورئيس قسم جراحة المخ والأعصاب في مستشفى 57. بالنسبة لجراحة أعصاب الأطفال في المخ بالتحديد، النافيجيشن النافيجيشن اللي موجود هنا مختلف عن بقية النافيجيشنز، بس عشان النقطة دي تبقى واضحة إن النافيجيشن الS8 اللي موجود في السلام مش بيحتاج ان احنا نثبت راس العيان بمسامير في الترابيزه زي الادلت الكبار في السن. كل النافيجيشنز تانية بنثبت الراس. الفرق ايه بقى؟ ان هو الاطفال تحت سن 3 سنين ما بنحطش فيهم، ما بنثبتش راسهم بمسامير في الترابيزه، وبالتالي نقدر نستخدم النافيجيشن ده في الاطفال. بمعنى اخر ان النافيجيشنز التانية واللي بيتأجر في كل المستشفيات الاخرى ما ينفعش يستخدم في الاطفال. Again, the other types of navigations that is been rent in the rest of the country could not be used in children less than 3 years old. This is the only one that could be used for children less than 3 years old. For skull-based tumors اللي هي أورام قاع الجمجمة، النافيجيشن is very helpful لأن احنا حالات كتيرة منها مش محتاجين غير ان احنا ناخد بايوبسي أو عينة when continue by adjuvant chemo أو radiotherapy. والنافيجيشن is very helpful في الحكاية دي لأن احنا ممكن ناخد العينة دي عن طريق الاندونيزل أو عن طريق البير هول، يعني خرم صغير في السكال، نخش ناخد عينة وبعد كده نكمل بأدجوفانت ثيرابي. معظم السكال بيس تيومرز الديستركتيف بتمشي كده، أو الاندونيزل عن طريق المناخير بالمنظار. بنستخدم النافيجيشن بيسهل الجراحة وبيسرع وقت العملية وبيساعد على الاستئصال الكامل الآمن للورم، لأن هو الطفل محتاج good quality of life فيما بعد. To have a good quality of life you have to be a safe surgeon. To be a safe surgeon you have to use all the tools that makes the surgery safe. التولز دي أهمها هو النافيجيشن.
شكرا دكتور بلتاجي. شكرا. دكتور محمد رضا، ادينا فكره كده عن السيرفيسز اللي في دار الفؤاد اكتوبر، وبردر الاكسبيرينس بتاعتك في النافيجيشن ترانسفينويدال او في البوستيريور فوسا.
Good evening, ladies and gentlemen. It is my
بالعربي
تمام. هو طبعا انا كان ليا الشرف ان انا اكون جزء من مجموعه ألاميدا وامسك جراحه المخ والاعصاب في مستشفى دار الفؤاد 6 اكتوبر. طبعا انا من دي 1 لقيت سبورت جامد جدا من البورد، من مستر ميراج، من دكتور رامي، من دكتور بسيوني، لان احنا كان عندنا بعض الحاجات اللي محتاجينها، منهم مايكروسكوب. طبعا مش بقوه الميكروسكوب بتاع السلام، بس قدرنا برضو نجيب السنه اللي فاتت مايكروسكوب لايكا بروفيد، واحد من يعتبر من اقوى الميكروسكوبات ايضا في الشرق الاوسط.
وفولي ابجريدبل، يعني هو ممكن يبقى ابجريدبل زي اللي عندنا.
تاني حاجة كان أي انسترومنتيشن بنحتاجهم بنطلبها بحيث إن نقدر نعدي سيفتي سيرجن، جراحات تبقى كلها آمنة، كنا بنجيب كل الآلات اللي محتاجينها. تالت حاجة البرنامج الانترناشونال اكسبرتيز، إن احنا نجيب جراحين مخ وأعصاب من أقوى الحتت في العالم يغطوا الحاجات اللي فيها ديفكتات عندنا. يعني احنا ما عملنا سيرش لقينا ان احنا عندنا الاطفال اللي عندهم الشلل الدماغي بيعانوا من مشكله الشد في عضلات الرجلين اللي بيمنعهم عن المشي، فكنا بنحقنهم يا اما مع النيورولوجي، بس دي بتبقى حاجات تمبرري. لكن اللي بيحتاجوه نوع من انواع السيرجري واللي بنعملها في مصر بنعملها بالصوره التقليديه، فكانت نتائجها ان بيبقى الظهر فيه الم اكتر على الطفل، فكان الناس دايما بتبعد عنها. فما عملنا سيرش لقينا ان اقوى سنتر هو في انجلترا، جريت ارموند هوسبيتال بتاع تشيلدرن. فما كلمنا البورد قالوا لنا احنا ممكن نحاول نراسلهم، وقدرنا نراسل البروفيسور كريستيان اكوالينا، وهو فعلا قدر يعني يجي، وابتدينا نعملها عن طريق المينيمال انفيزيف. يعني احنا بنعمل الجراحات دي دلوقتي لنوعيه الاطفال دي عن طريق يعني جرح بيبقى من سنتي من 5 سنتي، عن طريق استخدام الميكروسكوب اللي جبناه، عن طريق نيوروفيسيولوجي انتر اوبراتيف، يعني بيبقى معانا الرسم العصبي المتواصل، بيبقى معانا انتر اوبراتيف سونار، بنستخدم السونار اللي موجود علشان يحدد الحته اللي فيها المشكله اللي بتدي اشارات خاطئه وبتعمل الشد في الرجلين. فابتدينا نخش من جزء صغير جدا في الضفيره العصبيه بدل ما كنا بنفتح الظهر. فكل السبورت ده وابتدينا نعمل حالات، ابتدى الريت بتاعنا طبعا بوجود الحاجات دي ارتفع اكتر من نسبه 200% في السنه الاخيره. طبعا برضو عايز اتكلم على موضوع النافيجيشن. هو النافيجيشن ساعات بيبقى يعني بيمنع ضرر. ازاي؟ ساعات في بعض الحالات بيبقى اصلا مش ورم، بيبقى انفكشن، وساعات ما بنفتح الانفكشن دوت بيعمل فليرنج ليه، فاحنا بنشخص بيه عن طريق ابره، بنخش ناخد عينه 1 داي بروسيجر، ويعني جراحات اليوم الواحد زي ما بيقولوا، وبيخرج العيان بعديها وبنطمن ان هو ده مثلا لا ده مثلا خلاص ده حاجه مثلا هياخد كيماوي اشعاعي، لا ده طالع التهابات بيتحول في سكه ثانيه. فده بيدينا فرصه كبيره جدا ان احنا نفرق بين الحاجات، التشخيص، لان هو اهم حاجه في الطب ايه؟ التشخيص اولا والسيفتي، هم دول الحاجتين مهمين. فهو الجهاز الملاح بيدينا التشخيص، وبعد كده بقى نشوف ايه اللي نعمله. ده هيحتاج اوبن سيرجري، ده هيحتاج يعني فتح كامل، ده هيحتاج كيماوي، هيشعاعي، مضادات حيويه. فالنافيجيشن اسينشال طبعا، الى جانب استخدامه بقى في الجراحات نفسها، ان هو مش التشخيص ازاي، السيفتي، ان ابعاد الورم ايه، نخش التراك ايه، نبعد عن المراكز الحيويه، مراكز الحركه، مراكز الكلام، فبيدينا. وحتى لو احنا تهنا في الحاجات اللي في العمق في نص العمليه، في ثانيه واحده بنحط النافيجيشن احنا فين. اكنه زي النافيجيشن، انت ماشي بالعربيه تهت في السكه، شغل جوجل مابس يعرف مكانك فين، طب ايه الطريق اللي وصلني سيف وامن. فهو طبعا النافيجيشن لا غنى عنه في العالم دلوقتي كله. طبعا وجود احدث الحاجات ده بيدي قوه شديده جدا للمجموعه عندنا، ونتمنى دايما يبقى السبورت ده موجود.
شكرا. اما بنقول انه سنتر اوف اكسلنس في النيورو ساينس، جزء مهم جدا من الموضوع الانترفنشنال نيورو راديولوجي. لو احنا عرفنا انه المخ بياخد 25% من الاوتبوت بتاع القلب، يعني 25% من الدوره الدمويه، بيبقى في اورام الدوره الدمويه بتاعتها عاليه جدا. الحقيقه انا كان يعني ساعدت كذا مره انه الحالات دي، لان احنا سنتر اوف اكسلنس والامبولايزيشن موجود. الاستاذ الدكتور فاروق حسن استاذ الاشعه التداخليه بننظم مع بعض انه المريض يدخل ويتعمل له الامبولايزيشن زي ما هو هيكلمنا، وبعديها بيومين ندخل نشيل الورم باقل قدر من فقدان الدم.
هو الحقيقه يعني التخصص قسطره المخ من التخصصات الحقيقه اللي حدث فيها تطور كبير قوي في السنين اللي فاتت. اضافت بعد جديد كبير في علاج عيانين كتير قوي، سواء العيانين اللي بيحتاجوا جزء من العلاج بتاعهم بشكل جراحي زي الدكتور رامي ما اتفضل وقال. العيانين اللي عندهم اورام المخ اللي بنخش بقسطره نعمل حقن للشرايين المغذيه للورم قبل ما يتعمل جراحه، فنسهل الامور للجراحه ونقلل النزيف اثناء الجراحه. او سواء العيانين اللي بيبقى عندهم نزيف في المخ نتيجه ان في تمدد شرياني انفجر، فبندخل بالقسطره من الرجل نوصل لغايه تمدد شرياني ونقفله، او وحمه دمويه نازفه في المخ ندخل بالقسطره ونقفلها، او الحالات حدوث الجلطات المخيه زي الدكتور احمد عبد العليم ما تفضل ووضح في المحاضره ان العيانين دول كتير منهم بيحتاجوا ان هو نلحقهم بالقسطره في اول كام ساعه ونفتح الشريان فننقذ المريض، سواء ننقذ حياته او ننقذ اللايف ستايل بتاعه. فالحقيقه بقى في الحقيقه يعني اي فعلا نيورو ساينس سنتر عايز ان هو يبقى يعني بيقدم خدمات يعني كومبريهنسيف وانتجريتد ويبقى كل حاجه متاحه فيها، بقى الحقيقه جزء من اساسي من الخدمات اللي بتقدم هي القسطره المخيه او النيورو انترفنشن. فمش عايز ابقى متحيز، بس الحقيقه مجموعه ألميدا لو الواحد يشهد لها، فمعرفش الناس تعرف ولا لا، بس هي اول مكان اتعمل فيه ميكانيكال ثرومبكتومي في مصر على الاطلاق كمستشفى برايفت كانت مجموعه ألميدا. واول ستروك سنتر بيقدم ميكانيكال ثرومبكتومي 24/7 في مصر كان مجموعه ألميدا. وبدون اي تحيز ما زال حتى الان السيرفيس اللي بتقدم كستروك سيرفيس مانجمنت كومبريهنسيف من اول ما العيان يدخل والنيورولوجي بيشوفه لغايه ما بيتعملوا الانترفنشن لو محتاج، ولو محتاج حاجه سيرجيكال بتعمل، ما زال انا ادعي ان ما زال الليد لمجموعه ألميدا من ناحيه سواء التيمز اللي شغاله، من ناحيه الاجهزه اللي متاحه. مستوى الاجهزه اللي متاحه ما فيش مستشفيات برايفت بتجيب اجهزه بهذا الشكل، الاجهزه الباي بلين، الاجهزه الموست اب تو ديت، فعلا ما فيش حد في البرايفت بيعمل كده. دي مستوى اجهزه ما بتجيش غير في الاماكن الحكوميه اللي معاها فلوس كتير. الحقيقه مستوى من الاجهزه مختلف، تيمز عندها فيري جود اكسبيرينس من اول دخول العيان بيتعامل معاه ازاي، دقيقه بتفرق مع العيان لو بنتكلم في حاله ستروك. فالحقيقه فعلا I think Alameda is leading يعني this branch في مصر الحقيقة بدون أي تحيز يعني.
شكرا دكتور فاروق. دكتور احمد عبد العليم استاذ الامراض العصبيه، احنا كان في يمكن حالتين او حاجه منهم بنوته كده كانت صغيره كان عندها ابيليبسي وعملنا لها، كان عندها ليجن كورتيكال ديسبليزيا وعملنا لها العمليه والحمد لله مشيت كويس. تصور حضرتك ايه ازاي نقدر نعمل الابيليبسي يعني الكومباينيشن ما بين النيوروفيسيولوجي والنيورولوجي والنيوروسيرجي في الابيليبسي سيرجي؟
طبعا الجراحات للناس اللي عندهم مرضى الصرع ومرضى اضطراب كهربة المخ، في منهم مجموعة احنا بنسميها الصرع المستعصي، ده اللي هو بياخد علاج. بنبدأ معاه بالطريقة التقليدية ان احنا بنبدأ بأدوية، بنجرب خط علاجي ثم خط تاني او تالت، اذا فشل بنبتدي نحط اكتر من دواء مع بعض. ففي نسبة من المرضى ما نقدرش ان احنا نظبط العلاج بتاعهم بالأدوية، وبالتالي المريض ده حياته متوقفة، يعني التشنجات دي مخليه المريض ده مش قادر يدرس، مش قادر يتجوز، مش قادر يتحرك. فهنا بقى بيجي دور الجراحة. الحقيقة برضو تاني يعني الجراحات النوع ده من الجراحات لا يمكن عمله الا في سنترز اوف اكسلنسز فيها تيم متكامل من الثلاث تخصصات اللي حضرتك قلت عليهم. يعني ما ينفعش انا ابقى قاعد في عيادتي واقول للعيان روح كده حد هيكشف عليك وبعدين ابقى تعالى لي وبعدين روح كذا، لا، ده تيم بيقعد مع بعضه يعمل اختبارات، والاختبارات دي بتحتاج خبره في قراءتها. يعني دكتوره نيفين عارفه انه مش مجرد رسم مخ عادي او كذا، لا، ده الموضوع كبير جدا، وفي حاجات الى حدود ان احنا بنعمل رسم المخ وبعض الاختبارات داخل العمليه نفسها علشان نبقى متاكدين ان احنا ما نضرش حاجه زي ما احنا بنعمل العمليه. عندنا مثلا مركز الكلام من الحاجات المهمه جدا ان احنا ما نضرهاش، ودي لها فحوصات بتتعمل ولها حاجات تتعمل داخل الجراحه نفسها. وبالتالي احد الحاجات اللي برضو تعلم علامه ان ده سنتر اوف اكسلنس انه يقدر يعمل هذا النوع من الجراحات مبنيه على امكانيات متوفره وعلى الخبره. الحقيقه يعني انا عايز اتك على حته الخبره دي. يعني الخبره دي حاجه ما نقدرش ان احنا نتجاهلها، والخبره دي بتيجي من نتائج فعليه وبتيجي من حاجات احنا بنشوفها بنفسنا. وبالتالي مهم جدا حته الخبره مع التجهيز وانا رايي ان الحمد لله يعني اعتقد ألميدا كل مستشفياتها مجهزه بالاكويبمنت ده، وكل التيمز اللي شغاله فيها عندها القدره على اتخاذ هذه القرارات، وعندهم الخبره في مثل عمل مثل هذه الحالات، يعني في حالات قبل كده يعني.
شكرا. دكتورة نيفين، تكلمينا بقى على يعني ايه اللي بتشوفيه او ايه اللي بيخليكي في رسم المخ العيان ده محتاج يعمل او يبقى حاجه ريزيستنت ابيليبسي محتاجه تعمل سيرجري.
مساء الخير. اكشولي بالنسبه لرسم المخ الاول هنتكلم على رسم المخ العادي اللي هو الكونفنشنال ديجيتال اي اي جي. رسم المخ العادي بيبقى عباره عن نظام اسمه 1020 سيستم، عباره عن الكترودز بتتحط على المناطق ارياز في السوبرفيشال على البرين، فور اكزامبل فرونتال، تمبرال، بارايتال اند اوكسيبيتال، ان انا عشان اقدر اغطي كل الارياز بتاعه البرين. العادي الروتين اي اي جي زي ما احنا قلنا احنا بنعمل في العادي من 20 to 30 minutes علشان ان انا اقدر ان انا اكابتشر اي تغيرات في رسم المخ. التغيرات بمعنى ان هي بؤره او اي تغيرات اخرى زي ما نقول سلوينج او بطء في رسم المخ. طبعا كل ما بزود فرصه ان انا اطول المده او ان انا اعمل رسم المخ، يعني انا ممكن اول رسم مخ اعمله يطلع طبيعي جدا ما فيهوش اي حاجه اكشولي. علشان كده دايما في عندنا في السلام وفي كل المستشفيات بنطلب فولو اب للبيشنت، نطلب فولو اب بيزيد لدرجه ان رابع رسم مخ ممكن يزيد بنسبه 90%، بتبتدي تظهر الابليبتي فورم ديسشارجز او البؤر الصرعيه. طبعا بالنسبه ده بالنسبه للي هو رسم المخ العادي. غير كده كمان انا بنعمل رسم مخ مطول ممكن من ساعات up to days علشان ان احنا نقدر ان احنا نحدد مكان البؤره بالظبط، واقدر كمان احدد مدى السيفيريتي بتاعه العيان وهل العيان ده ريزيستنت اور نوت. لان انا السيفيريتي بتاعه الاي اي جي لو انا مثلا عندي في رسم مدته ساعه، لو انا لقيت اكتر من 60 ايبوك، 60 ايبوك يعني 60 صفحه، 60 صفحه فيها بؤره او ديسشارجز زي ما احنا بنقول، لا العيان ده بيعتبر بنحطه انتو كونسيدريشن ان هو ممكن لو مش مستجيب كمان على العلاج يتحط ان هو ريزيستنت. بالنسبه لحالات التمبرال لوب ابيليبسي بالذات او اللي هي التشنجات الصدريه والاكسترا تمبرال بيبقى في عندنا فيها اوفرلابنج، بمعنى ان انا ممكن البؤره تبقى في ناحيه واحده ويظهر لي عندي في رسم المخ في ناحيتين. في الحاله دي انا ببتدي اول حاجه غير ان انا بعمل رسم مخ مطول ولونج تيرم اي اي جي ابتدي احط الكترودز زياده عن النظام المتعارف عليه اللي هو 1020 سيستم اللي هي سفينويدال الكترود. ببتدي الاول بنون انفيزيف الكترودز بتبتدي تحدد لي، ببتدي برضو اتابع العيان عشان اشوف السيجر اونست الزون بتاعت السيجر اونست. لو انا هما في الناحيتين فان انا بحاول ان انا اشوف هل بتبدا في ناحيه قبل ناحيه ولا لا. لو انا فشلت في ده كله لا ببتدي بقى ان انا ادخل انفيزيف، بنحط انفيزيف الكترودز بنبتدي نعرف منها فين السيجر زون بالظبط بادئه فين بالظبط. طبعا التايب اوف الكترودز يا اما بتبقى عندي يا اما دبت الكترودز بتتحط في العمليات او ان انا بحط جريد. بالتالي بقدر ان انا احدد الديسشارجز اللي بتطلع اثناء الرسم. زائد كمان بتبقى في حاجه اسمها قلنا سلوينج اللي هو بطء في جزء ما من المخ. طبعا بتبقى طبعا قصه ان البؤره انا ببقى اتجاهي اكتر ان انا احسن البؤره مش ان انا احسن السلوينج. وبس بعد كده هو بوست سيرجيكال اكيد بيتعمل له فولو اب وبنشوف الرسم وبيتعمل كمان prolonged recordings علشان نشوف هل البؤره اختفت ولا لا. he needs further treatment or not.
ميرسي دكتوره نيفين. انا كنت عايز اقول حتى كمان انه في الانترا ميدالري تيومرز الاورام اللي داخل الحبل الشوكي نفسه ما اعرفش الدكتور هشام نافع كان هنا، انا مش شايفه دلوقتي. مشي طيب. الاستاذ دكتور صلاح حماده هتكلمنا حضرتك عن السيرفيسز في دار الفؤاد مدينه نصر.
مساء الخير عليكم. انا اسمي صلاح حماده، استاذ جراحه مخ واعصاب في جامعه عين شمس. طبعا انا اتشرف ان انا اكون قاعد معاكم النهارده. الدكتور بسيوني يعني ما قدرش يجي فانا فيلينج هيز بليس. اتمنى اكون يعني ضيف خفيف عليكم. الاول انا عايز بس اقول حاجه، ان كل الفاسيلتيز اللي اتكلمنا عليها النهارده ديت بنسميها essential prerequisites علشان يبقى في center of excellence. يعني من غير الحاجات ديت اصلا ما فيش center of excellence. يعني لا تتوقع excellence في الميديكال سيرفيس من غير الفاسيلتيز ديت. يبقى اول ستيج ان لو مكان ما فيهوش الاماكن ديت فهو في الغالب مش هياخد the desired service for the patient. دي اول نقطه. تاني نقطه ان الحاجات دي لوحدها مش ضمانه for successful center of excellence. السكسس ان البيشنت اوتكم، ان البيشنت هوسبيتال ديوريشن، ان الريتيرن تو ورك، كل الحاجات المهمه جدا للمريض والمهمه جدا للكفرنج انشورنس بتاع المريض مش هتتحقق لو المكان مش سيف وما فيهوش الفاسيلتيز. ولكن عليهم كمان البيرسونيل، بمعنى ان ممكن يبقى في واحد عنده عربيه كويسه جدا 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 بس ما بيعرفش يسوق، هيخبطها في اول شارع. يبقى المهم جدا ان اللي بيسوق ده يكون بيعرف يسوق. وده اللي انا هخش عليه، ان المجموعه بكل مستشفياتها انا متاكد ان فيها زي منتخب مصر بتاع different subspecialties. يعني ما فيش تخصص دقيق في النيورولوجي او في النيوروسيرجي او في النيوروفيسيولوجي او في اي حاجه تخص النيوروساينس ممكن نحتاجها في مصر الا لما هتلاقي احسن ناس في احسن سب سبيشالتي متواجدين في المستشفيات المختلفه. فوجود منتخب مصر مع الفاسيلتيز اللي موجوده ديت هي الضمانه الحقيقيه للسكسسفul سنتر اوف اكسلنس. مش مجرد بقى سنتر اوف اكسلنس وخلاص، لا ده كمان بقى سكسسفul بكل المعايير اللي تهم كل الناس المعنيين بعلاج المريض، اذا كان الدكتور او المريض او الناس اللي بتشرف على علاج المريض. وده بيتحقق مش بس بالبروبر تريننج الممتاز جدا اللي كل الزملاء الافاضل اكيد على اعلى مستوى، ولكن اللي بيسموه دلوقتي في المودرن مانجمنت اللي هو الكوربريت انفايرمنت او الهوسبيتال انفايرمنت. الهوسبيتال انفايرمنت از ات ا هابي انفايرمنت، الناس اللي فيه بتشتغل بحب، بتشتغل بقلب، بتطلع احسن ما عندها علشان في الاخر يبقى كله وين وين سيتويشن، كل الناس مبسوطه في الاخر خارجين مبسوطين. ولا الهوسبيتال انفايرمنت او الفايب بتاع المكان نيجاتيف، فبالتالي الاوتكم مش مرضي لكل الاطراف، ممكن مرضي لبعض الاطراف. وده اللي انا حسيته فعلا مع الدكتور بسيوني ومع الدكتور رامي ومع المجموعه في دار الفؤاد مدينه نصر، ان الهوسبيتال انفايرمنت نفسها مفيش حاجه صغيره او كبيره ممكن تكون بتعيق البوزيتيف اكسبيرينس مش بس للمريض ولكن البوزيتيف اكسبيرينس للميديكال تيم كمان، الا لما الناس بتحاول دايما تذللها وتحاول تاوفركم المشكله اللي ديت علشان خاطر ما تبقاش عقبه، علشان المنتخب يقدر يستغل الفاسيلتيز الممتازه الموجوده ديت ويطلع احسن اكسبيرينس فور ايفري ون. فده النقطه الاولانيه. النقطه الثانيه لو تسمح لي دكتور رامي اتكلم على النافيجيشن في الابيلابسي سيرجري، علشان الابيلابسي سيرجري اللي تفضل الدكتور رضا اتكلم عليها، ان في بؤره في سطح المخ او عميقه في المخ بتطلع كهرباء غير طبيعيه، فالمريض بيجي له صرع مش راضي يستجيب للدواء. ببساطه شديده عنده صرع بيتشنج 10 مرات في اليوم، 20 مره في اليوم، وكل ما بياخد ادويه ما بيتفيدوش. فبالتالي بالفاسيلتيز اللي موجوده في المجموعه نقدر نحدد فين، سوري انا اسف في التشبيه، البطاريه اللي عماله تطلع كهرباء غير طبيعيه. فبالتالي نقدر نشيل البطاريه البايظه ديت عن طريق استئصال جزء من القشره بتاعه المخ. والاستئصال دوت علشان يتم بشكل امن وفعال لازم الفاسيلتيز اللي كلنا اتكلمنا عليها، اذا كانت مايكروسكوب او اذا كانت نافيجيشن او اذا كان الانترا اوبراتيف نيوروفيسيولوجي، علشان في الاخر يبقى في سيف سكسسفul ابيلابسي سيرجري. والنافيجيشن والمايكروسكوب والانترا اوبراتيف نيوروفيسيولوجي من الحاجات الاساسيه لنجاح الفكره ديت. والفكره ديت ممكن تكون جديده لناس كتيره، ازاي يعني مريض عنده صرع هنعمل له عمليه، ولكن الفكره دي راسخه بقى لها 100 سنه في العالم كله وموجوده في مصر، وكل المستشفيات فيها اساتذه افاضل بيعملوا موضوع الابيلابسي سيرجري ده وبيعملوا كفاءه عاليه جدا جدا جدا. ولكن محتاجين بقى الفتره الجايه ان شاء الله يبقى في الاويرنس، استخدامات التولز المختلفه اللي اساتذتنا الافاضل تفضلوا بيها في الديفرنت سب سبيشالتيز، علشان المعلومه انا اسف تسيركيوليت بشكل كامل، يبقى كل المعنيين بالتيكينج كير اوف ذا بيشنت يبقى عندهم المعلومه ديت ان المريض ده ينفع يتعمل له ده في المكان ده مع التيم دوت. اسف لو قطلت عليكم، وشكرا دكتور رامي.
شكرا. استاذ دكتور طارق لطفي، بس بالعربي كده هسألك، قول لنا السيرفيسز اللي موجودة في السلام الدولي للقطامية بالنسبة للنيورو ساينس.
مرة ثانية أنا دكتور رامي بيديني فرصة أخرى عشان أنا اتكلمت اوت اوف ذا سكوب. شكرا دكتور رامي. طبعا احنا الابن الأصغر للمجموعة، احنا ابتدينا في يعني السنة اللي فاتت في آخر السنة حوالي شهر 8، وابتدينا بجد في شهر 12 وواحد. يعني أنا عايز أقول للناس كلها إنه أهم شيء وإحنا حرصنا عليه هو أول واحد بيقابل المريض في أوضة استقبال الطوارئ. إن ده أنا شايف إن هو أهم واحد موجود في المستشفى، لأن هو اللي بيدي الانفورميشن لكل الناس التانية. هي دي نقطة الانطلاق اللي بيبتدي بيها المريض طبعا رحلته. فلو اللي شافه ده مش ما عندوش المعلومات الكافية والجادجمنت المعقول ان هو يقدر ينقل المعلومة للستاف اللي معاه، ممكن العيان ده يبقى لوست. ولو ما بيعرفش ياخد مانجمنت مظبوط في الوقت المظبوط، العيان ده ممكن يبقى لوست. فانا اي جارانتي ان احنا عندنا في السلام القطامية يعني one of the best teams للاستقبال موجودة في الطوارئ، وفي كولابوريشن الحقيقة قوي جدا ما بين كل الأقسام، إذا كان الباطنة أو النيورولوجي أو الأورثوبيديك أو الاي سي يو. التيم بتاع الانستيزيا عندنا من أقوى الانستيزيا الحقيقة اللي موجودين من كل الجامعات، من عين شمس ومن القصر العيني، معهد الأورام، اساتذه عظام، واحنا عملنا معاهم حالات صعبه قوي 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 في العمليات واستحملونا كتير. كل السبيكترم بيتعمل دلوقتي في السلام القطاميه، من اول حتى النيورو انترفنشن، من المناظير بتاعه المخ، مناظير قاع الجمجمه، مناظير اورام المخ، كل حالات السباين، سواء اذا كان الديسك سيرجري مايكروسكوبيك، والاورام بتاعه الحبل الشوكي واورام المخ. وللحاجات البسيطه طبعا بنستقبل كل التروما بكل انواعها، وعملنا تروما كتير قوي. يعني هوبفولي ان احنا ان شاء الله نقدر نكمل بنفس الحماس، وعندنا تيم قوي جدا لسه يعني مشارك معانا من حوالي شهر او 2. هوبفولي ان شاء الله نقدر نكمل. وانا متشكر جدا لكل المجموعه والكولابوريشن اللي ما بين الاقسام، وشكرا جزيلا.
اشكركم. ثانك يو سو ماتش. يعني تتفضلوا. مستر نيراج.
يس.
4 hospitals, please, on stage. Dr. Yahya, Dr. Osama, Ms. Jasmine, Dr. Mazen, Mr. Bopathy. Today we have the privilege of honoring 2 extraordinary professors who made invaluable contributions to our hospitals. It's with great pleasure that we present a symbolic gift recognizing their exceptional achievements and dedication to their profession. We'd like to invite Professor Hussam Salah, the Dean of Faculty of Medicine, Cairo University, Qasr Al Aini. Congratulations. Professor Rami Amin, the head of Department of Neurosurgery, Cairo University, Qasr Al Aini. Exactly. Congratulations. Thank you, dear. Thank you, CEOs. Thank you. Ladies and gentlemen, at this point we have reached the end of our sessions, and I'm sure you are all eagerly anticipating the delicious dinner that awaits us. But before we adjourn, let us capture this memorable evening with a group photo, symboling our unity and shared commitment to advancing healthcare. I'm honored to have been given this opportunity to deliver this wonderful event to you. I hope you've all enjoyed as much as I have. Please join us on stage. All of us, yes, yes. All of us, please. Everyone, a group photo, please. Music? Music. Maybe ladies upstairs and men down? Yes. Please, everyone, Dr. Mitwalli, please, everyone. Everyone on the table, everyone in the foyer, please. كلنا يا جماعة, please, صورة جماعية. سيلز تيم في الفويه بليز تدخلوا الناس ناخد جروب فوتو مع بعض.
Okay, class, who would like to do problem?